said, oh. So next time we get into a fight, I'm going to pull out my iPhone and I'm going to play you what you just said and say, see, I'm still a nice guy. Hey, everybody. So really great to be able to talk to you on this topic. I've been sort of in and out for the sessions for the yesterday and even less so today. So I know some things have been covered, but what I'd like to cover is the healthcare business model. What I'm going to try to do is a couple of things here. I'm going to I'm logged into two places, so I'm going to good. I can share my screen. Good. So I'm sharing my screen here, and I'm talking here, which is exactly what I wanted to do. So I'm going to open up my slides. There we go. Can everybody see that, I hope? Good. Excellent. So thank you for that nice introduction, and really, being part of a place where I can collaborate with people, who, like the organizers of this class or course is really such a pleasure, and then getting to meet the entrepreneurs and the PhDs who are, the people who are involved is really such a pleasure. I mean, it really is. It just reminds me that learning or teaching is really very two-way learning, and it's delightful to hear the ideas that people have. So, and the other thing, I would really like to make this as interactive a discussion as I can. So I'll try to stop a couple of times and maybe ask some questions. We've got a couple of polls built into the presentation, and I'll try to monitor. But if somebody has a question and wants to interrupt, there's probably a number of ways you could do that. You can raise your hand electronically, or I'm very comfortable if you just take yourself off mute and ask a question. I'll as long as I hear it, I'll stop and we can have the discussion. So a little bit in keeping in the theme of Kyle Jansen, not so much about pure entrepreneurism, but I think it's worthy. I think it's worthwhile to go through some basics. Despite the fact that some of this might feel very basic and very fundamental, I think it's worth it to go through some basics so we're all on the same page as we're thinking about healthcare business models and maybe some of the logic behind some of them. But before we get into the healthcare business model, I want to start with this poll. And before I even set it up, I want to ask the question: who has the power in this classic triad of patients, payers, and providers? And I don't know who's running the polling, whether it's Barb or somebody else, but this would be the first poll that I would love to send to the students.
It is me. You ready for it?
Yep, we're ready for it now. Yep. For this and the next poll that we have, don't I don't want you to think too much about it. Actually, I'm not going to vote myself, so I'm going to just close that. I don't want you to think too much about it, but just let's see. Just try to because this could have a lot of implications, such as, well, what provider are we talking about, or who's the payer that we're talking about. All right, great. So you can see that only a couple of people said patients, and only a couple of people said providers, but most people said payers.
This is like the presidential election, Greg. 110% response.
That's right. Well, Nevada hasn't been counted yet, so we're hoping that this turns the tide. I find this answer that you gave fascinating, because if we ask this question maybe 20 years ago, 30 years ago, I think the answer would be different. You know, certainly if we went back, say, 50 years, the answer would be very solidly on the provider side. That basically doctors are in the decision making and the power position in the healthcare system. They make the most money, and when they prescribe something, the payer pays for it, and the patient, you know, basically, you know, does what they're told. That shift does, you know, is it completely on the payer side, you know, or not? I mean, obviously there's been a tremendous shift, but one of the things that, you know, ideas that I'd like to seed, you know, during you know, this discussion and maybe in general, is that, you know, it's shifted from one player to another. Don't be surprised if it continues to shift. And I believe that there's a shift that we're beginning to experience going towards the patient for a number of different reasons. You know, it's a little bit outside of the, you know, the realm of this talk to you know, do an adequate deep dive on that. But I'd like to give at least some ideas of you know, of that shift. But before we get into that, you know, let's talk about a little bit more about. Let's see, how do I advance my slides? There we go. So you know, the fact that everyone chose, or most people chose one. I mean, it's sort of set up that way, but it's sort of interesting. If this were a balanced healthcare triangle, and if providers had a lot more power, if patients had a lot more power, we'd probably, in this small survey, get a little bit more of a balanced response, you know, roughly 30% in each category. So why is it that, you know, and I guess I should have asked this as a question before I jump to my slide, but again, let me sort of open this up. Why is it that there is such a imbalance of power in the healthcare system? And part of this imbalance is sort of is quite critical, because I mean, let me ask a different question. Who is the beneficiary of the healthcare system? That is a real question.
Pharma? Is it
for-profit insurance companies?
Okay, insurance companies. Well, why do you say insurance companies are the beneficiaries?
Because they're making a profit.
Because they're making a profit. Okay. Any other ideas?
Providers?
Providers? How is it that why are they the beneficiaries? Pardon me?
Maximizing their profit.
Maximizing their profit. Okay.
I think it's the patients, because at the end of the day, everybody's mission is to improve health outcomes, is to make the patient better. So the clinicians are there to save lives. The insurance people are there with the ultimate goal of saving life, but making money at the same time. So I think the patients are the real people, or the real beneficiaries, and that's where we are all here. That's why we're all here.
Yeah. I mean, I think that's right. You know, and that's the strange thing about this kind of, you know, this kind of question, and this healthcare system that's got three, at least in this simple model, it's got 3 points to it. All those answers are correct, but the pathology, the so-called pathology, I mean, from just a health point of view, well, you know, the side that the benefit that we should be sort of expecting here is patients receive care, right? I mean, it's healthcare. You know, that should be the thing that we're kind of talking about. However, in that system, there are equally strong arguments to say, well, you know, it's providers, it's their careers, it's their jobs, and they're making money, and they're, you know, getting, you know, writing papers, and they're doing research, you know, or it's the payers, you know, or perhaps it's the shareholders who support the payers, you know, and the stockholders who provide the financing, the capital for for insurance companies. You know, that the CEOs of insurance companies ultimately, you know, in some way, you know, answer to shareholders, because if their stock, you know, if their stock goes down, they get fired. So these systemic pathologies have been described as the principal agent problem, and so you know, the you know, defined by the fact that providers and payers are basically making decisions, life and death decisions, on the behalf of patients, and there's a struggle between each one of these nodes. Patients, because there's this principal agent problem, so patients want to get the best care. The best care, you know, in our capitalist system is expensive care, so they want to argue for the most expensive care. Payers, you know, that's a tension, because that the more expensive care they have to provide, the less profit they make. Providers are kind of caught in the middle, because on one hand they want to, you know, provide the best care, but they also want to maximize their own profits, which leads to other distortions that some of you probably are well aware of, such as, you know, increased procedures and an inappropriate delivery. I mean, one of the craziest, you know, examples is that you know, years ago it was found that there was an epidemic of liver fibroid, uterine fibroids in a particular county in, you know, Ohio. I might have the state wrong, and you know, and epidemiologists tried to figure out, like, what is going on, like what's in the water that's causing all these fibroids, because all these women were having hysterectomies, and the answer was there's no difference other than that county reimbursed at a much higher rate for hysterectomies than the adjacent counties. So there's lots of examples of perversities, and that perversity, you know, or pathology, is squarely on the providers. So there's a distortion of incentives. You know, it creates this kind of asymmetry, and there are these power shifts. All right, should we be depressed about it? You know, not per se. Before we get there, you know, I just want to sort of, you know, I don't want to dwell on all the, you know, all the items here, but, you know, it's, you know, obviously it's a lot more complicated than a simple triangle. You know, there's, you know, there are, you know, technology developers, there's different types of providers, there are federal, you know, agencies and bodies that oversee this. You know, there are, you know, different types of, you know, health networks and health information networks. And so, you know, there are collaborations and power struggles which lead to, you know, just the same thing, distortions and asymmetry between the different players. And if we, you know, really want to create a true map, then we get into very complicated networks. You know, Seth, I know, I think you're the one who introduced me to this concept of a hassle map. And so there's this thing called the healthcare hassle map, which is the way this is measured. It's kind of a marketing thing. Is you know, groups of people are asked to use keywords for pain points in their particular experiences, and you know, you can take it from different parts of the triangle, or you know, the different areas of the kind of that healthcare, you know, the players in the healthcare system, and just to say that there's, you know, asymmetry and distortion between say patients and payers is nowhere near a reflection of the complexity of the actual system. So the reason to get depressed about that is because there's no coordination of care, and it is, you know, incredibly frustrating to coordinate, receive, you know, get great care. I mean, you know, I don't know if you can see this. I've got a Band-Aid here. I actually traveled 3,500 miles to get my surgery done in Los Angeles, and went through months of hassle to get it done there. Because I thought that was the best operation, minor operation, but just the best thing I could get. But unbelievable hassles that probably 50 steps along the way could have fallen apart, and I probably would have received lower quality. And I'm sure everybody's got a similar personal experience when it comes to dealing with the healthcare system. Incredibly problematic. So let me ask an open question. So should we just be depressed about that, or is there anything potentially positive about this? And Seth, you can't answer because I know you know the answer to this question.
Gridlock is good for everyone.
Gridlock is what?
Is good for everyone.
Explain why.
Well, all the stakeholders continue to benefit, except that the problem gets kicked down the line and doesn't get solved.
Okay, yeah, all right. Yeah, gridlock, I mean, it is fascinating. There is a strong benefit to the complexity, the gridlock. I don't know if how many people are aware. The number one employment sector in America is healthcare. It used to be government, but healthcare has surpassed it about a year ago. That I think what politician is going to stand up and say, I'm going to clean all this up and take half the costs out of healthcare? Well, that's
Needs
tens
to
of
happen.
millions of people who are employed. All right, so that's one point of view about the gridlock. But any other comments that we would say, we shouldn't just kind of shoot ourselves in the head because when we see something like this?
Well, hopefully, people get frustrated enough who know kind of the, know a little bit, and they actually try to come up with solutions to this. So, like one of the businesses we saw yesterday where, open beds of trying to coordinate this a little bit better so that way it does cut down on some of this hassle that you nicely mapped out.
Erica, I think that's an excellent way to put it. So, to tie it back to some of the previous lectures, each one of these hassles is basically a problem to be solved. And if you can address all of the things that an entrepreneur needs to think about, somebody needs to pay for it and you need a solution, not trivial things, but these are problem definitions. And each one of these problem definitions is potentially a market opportunity. So, so that's a little bit of why I wanted to sort of say, look, it's annoying, it's frustrating, it's difficult to get stuff done, but let's try to sort of find the silver lining here, which is that as entrepreneurs, we should think of this as opportunities. So, just to be kind of a nerdy academic here, we're talking about business models. So as we're talking about healthcare business models, let's talk about, what a business model, get into some definitions here. A business model is a description of a system that uses resources, processes, etc., in order to generate revenue. Now, revenue is considered the top line, and the top line is different than the bottom line. And the bottom line is gross income or net income or margin. I'm going to ask another completely softball question. Can somebody give me the definition of margin or net income? Hopefully softball, maybe it shouldn't be, maybe not softball.
I thought it was just the gross amount minus like your costs.
That's exactly right.
Made.
Right. It is. I didn't exactly see who said that. It's basically I mean, let's use that definition, right? It's the gross amount minus costs. So your revenue is your top line. Your revenue is your gross revenue, your gross income, etc. The bottom line, there's a bunch of different ways to define that, and I'll get there in a second. But your bottom line is basically your different ways to call it is net income, profit, or margin. Now, margin is another technical definition, which is exactly as you said. Your revenue minus your costs gives you margins. There's different types of margins. There can be gross margins and profit margins, etc. But I just wanted to kind of ask the following question in a simple way. And let me just make sure if this is. I think it's time for the next question. Let me just look on my other cheat sheet here to see that this is 2. Yeah, I think it's time for the next for the next poll. So then, if we could, if my pollster
Yep.
could help me out. So the question I'm going to ask. So now we're business students. So I'm gonna think about the bottom line, margins, or in this case, net income, your net profit. So my question is, what do you think is a respectable minimum margin for a sustainable business?
So
Right?
Greg, there's a typo on the last item. There's a $sign and it should be a percentage sign. Just
Okay.
You
All
ready?
right, that's no problem.
Okay.
So does everybody understand that question? So I'm asking the bottom line, which is, I think in the question it says margin, but what I'm asking is net income, net profit, after you take all of your money and subtract all of your costs on an annual basis, what is a healthy margin to say, yes, this is a healthy business, it's a sustainable business? So let's, what do you think would be appropriate here? And yeah, it should be percentages. So meaning, if it's 1%, that means that you've earned, $100,000 and you've kept $1,000 in profit. And profit, that's after you've paid yourself, after you've paid all your employees, after you've paid your IT developer. If you're a hospital, this means that after you've paid the doctors, you've gotten all your reimbursements from Medicare, all that stuff has happened. If you're a manufacturer, if you're a car maker, you've paid for the metal, the rubber, you've paid the employers, you've paid everything else off. This is the profit at the end of the day. Profit is also net of loans. All right, 10 to 25%, 1 to 3%, 1 to 5, 35 to 50%. Okay, good. Well, that's does anybody want to make a comment about why they gave a particular answer?
I was surprised you didn't have an answer for negative dollars.
Well,
especially given the number of large growth companies that are at the top. 15 companies in the S&P or something that are negative profit. But yeah, so I had answered the lowest amount simply thinking on investment back into your company and not having that number of profit sitting.
Right. That's an excellent it's an excellent point. I mean, this actually brings up a question. Does anybody know the difference between a nonprofit and a for-profit company?
It's really it's a tax definition.
Yeah, well, what do you know what it is?
Well, profits do not get taxed, and they keep all the monies inside that corporation until it's dissolved.
Okay. And did somebody else have a
Blue
comment?
Cross and Blue Shield is a nonprofit of Florida.
That's right. That's right.
They make $100 million a year in profit. You know what they do with it?
I worked in a nonprofit, and like the understanding of it was that we had to be mission focused in what we did rather than profit focused. And so we could generate money, but it all had to be feed into the mission as opposed to just trying to make more money.
Right. I mean, there are
I think the other option.
There are for-profit hospitals and not-for-profit hospitals. But yeah, as somebody else, Eric?
Yeah, I was thinking that also the notion that more and more nonprofits could be considered as not profit making, but certainly revenue making, that you can carry over, so you actually can make money and use it. The difference is, I would think, that is not given to stakeholders as dividends. Basically, other people are not profiting out of this revenue.
Mm-hmm.
It just kind of stays. But indeed, for profit, I mean, nonprofits still can make money.
Mm-hmm. That's right. That's right. So I think everybody was correct, but I think that the kind of the accounting definition is kind of the one that probably defines it from this point of view. It basically means the numbers that you guys just voted on, whether it's 5% or 20% or 50%, if it's a nonprofit, all of that extra 20% gets reinvested into the business. If it's a for-profit, you can do stuff with it which is not reinvested into the business. You can reinvest it, or you can give it to the shareholders of the company, or you can pay it out as a dividend, or you can put it in cash reserves and keep it. You keep it in cash reserves in case you want to make acquisitions. But anyway, let me kind of do the big reveal here. So you're absolutely right, Julie, that nonprofits are mission driven, but for-profits also have missions, and it's hard to find a for-profit company that doesn't have at least some elements of a feel-good mission. I mean, even Google, which is enormously profitable, their mission is organizing the world's data. It's like, yeah, hey, I can get around that. We can all rally around that kind of stuff. And somebody, else made the comment of like, you can have a negative profit. Definitely, you can absolutely have negative profits. The question that I wanted to focus on is, what's a healthy profit for a sustainable business? And I think this is critical for entrepreneurs to be thinking, because you're not going to get to a healthy profit for a long time. You're going to have, nonprofit as defined by your profits are going to be negative for a long time. You're going to have lots of costs, no revenue, but at some point, to build a sustainable business platform, you need to achieve a level of profitability that allows you to continue as an ongoing enterprise. And I think it's critical to be aware of what those numbers are, and also critical to be aware of what those numbers are in particular industries. So, a lot of information on this slide, but let me just pull out a couple of key points here. So, yeah, and maybe maybe I did the poll. Maybe I should have done the poll after this. Just as there's a lot of players in the healthcare system, as we just talked about. But I'm going to talk about hospital finance for portions of this talk, just because they're such big players and we're familiar with them, and they're kind of proxies to understand everything else that goes on. So, hospitals take in revenue, they can have academic revenue, they pay out, to physicians. They, interestingly, hospitals bill 3.5 times over what they receive in payments. Do you understand what I'm saying? that they have to bill 3.5 times greater than the actual revenue that they receive, meaning that 2 times what they bill, they expect not to see. And the margins for different hospitals come in, for-profit hospitals around 11%, not-for-profit hospitals around 7%, and public hospitals, which have a different mission, come even lower at 5%. So again, just kind of pause. I won't make a poll, or I won't force anybody to answer, but these are averages of hospitals in the United States between 5 and 11%. So what would economists say is a healthy margin for a business? It's actually more like 15 to 20%. And that means that our hospital system is operating at a sub-optimal profit margin category, which is somewhat problematic and somewhat concerning for anybody who needs to go to a hospital, which is lots of us, or work at a hospital, or deal with a hospital, or for some of us who want to be entrepreneurs and sell services to hospitals. If they're at 5% or less, that's considered razor thin. And a bunch of these, they're operating at 2% margins, which are really considered razor thin, very, very difficult to go through bumps in the road, such as COVID, a major bump. So 15 to 20% is kind of a good margin for overall. Again, your target in building a sustainable business should be around 15%, whether it's a big one or a small one. Another interesting fact, that the majority of small businesses, service and manufacturing businesses, operate below 10%, which is considered marginal. Should be somewhat concerning. But what is that? What's the implication of that? Well, let me actually ask that as a question. Well, what's the implication if a lot of businesses are operating at strictly defined marginal profit margins?
Not a lot of money to throw around to try new products that you're not sure are going to yield more profit?
That's right. Not a lot of money to reinvest in the business. Not a lot of money to throw around trying new products. Exactly right. Any other thoughts?
I was thinking of just limited capacity to even do what they were supposed to do, like even quality assurance measurement, benchmarking, just regular practices, which is very typical, for instance, in social services and in healthcare services. A main issue is that since their profit margins are so low, they just don't have capacity to integrate technology or add additional for professionals, even pay doctors in some opioid treatment programs, for instance. In contracts, which is, I think, a good point here in this conversation, government contracts generally do not include any additional, or less and less, they include additional monies for indirects, for instance. So leaving a lot of the social service and human service sector razor thin, basically not providing any additional support. So, and with this industry having very low profit margins, then it yields a very problematic issue for them to run a grant or a contract successfully, because they just don't have the technology or the additional supports to run that program successfully.
Yeah, I mean, I think those are excellent observations. It really interferes with the quality of the product and services that organizations can deliver, because there's less money to reinvest to maintain that high quality, and ultimately it can lead to even more devastating things, which is they go out of business and they start doing potentially bad things, to try to, and cut corners, get into a death spiral, and they disappear. And then, so if you think about, service businesses, the service economy is maybe operating at around 10% margins, which includes, housekeeping, nursing, teaching, etc. Manufacturing, on the other hand, is operating between 25 and 30%, and agricultural, which is farms, etc., is even below 10%. Well, it economically paints a picture of probably something that we experience in the United States, that I can get an awesome iPhone, but farms are going out of business. I can get an incredible car, but getting an incredible teacher is a little bit iffy. So, it's not all about the money, but it's all about the money. So it's just one way to point, to kind of think about that from a point of view. So in response to some of these pressures, the hospitals are slowly looking at their revenue models, and beginning to look at different ways that they can improve their revenue by, going back to that definition. How do they change their processes, products and services in order to improve their revenue, so that eventually they have more profit, which is the way, we're kind of setting up this model to measure, are they healthy, are they sustainable, can they reinvest to build higher quality products and, better services, etc. So how can you start tweaking the business model? So these are several examples of the way hospitals, healthcare systems, and provider practices are shifting over time. So, the traditional model for healthcare services is what was called a solution shop. Basically you show up and they just handle it. There's specialists there and they handle it, whatever comes through the door. They don't worry too much about setting up super efficiencies, because everyone gets kind of a customized solution. It's a bit of a high-end approach. Everyone kind of inside is considered a specialist. It's a bit of an expensive way to do things. It drives up costs. And for a long time in the 20th century, hospitals and providers had the luxury of more or less operating on this way, around this way. It's moving into different models, value-based or value-added processing. This is we'll get into value-based healthcare in a second, but this is how can a health network, providers or hospitals, add value in order to argue for higher revenue, such as adding different capabilities, such as diagnostic procedures or outpatient procedures, or adding new clinics. Or the other are these facilitated user networks, where you build larger networks to manage chronic diseases, to do a different set of services that goes beyond the traditional American way of you get sick and we treat it. How can we also get in front of that and start managing health, not just managing disease? Have you guys heard the term of value-based healthcare? Can anybody tell me in your own words how you define that?
Payment tiered to positive outcomes.
Payment tiers to positive outcomes?
Yeah.
Yeah, that's right. And what are you sharing? What is being shared in a value-based healthcare system?
First and foremost, data, I guess, because you have to measure something in order to be able to know whether it's good or what the outcome is.
That's right. That's right. Yeah. Andy, that's absolutely right. You need to share data to understand what the outcome is. Data also tells you what else. What else does data inform you about?
The profit sharing,
The profit sharing. Go ahead. I'm sorry, Annette.
I'm saying that I believe the sharing the savings of would otherwise be the cost.
That's right. That's right. So for this system really to work well, you need to be able to share information about the revenue as well as the costs in order to be able to manage the profits or split the profits. Any other ideas of what needs to be shared? Something a little bit more conceptual than data.
About risk.
Risk, yeah. Who said that?
This is Peg.
Yeah, the way this is set up, people's faces sometimes show up when you're talking, and sometimes they don't. So I won't try to guess who said that, but yeah. So conceptually, value-based healthcare is a risk-sharing method. So traditionally, if we think about kind of perversities and problems in the healthcare system, one of the main problems is that somebody else is taking on all the risk. Providers. There are some checks and balances, but do they really take on the risks? They don't necessarily take on the payment risks, and patients need to deal with the disease risk. The providers also try to offload risks on other people. Value-based healthcare is really designed around mostly products like pharmaceutical products and devices, but also around some services, with the idea that, and we're seeing this a lot more in very expensive types of pharmaceutical services, such as gene therapy and expensive oncology products. The idea is that there's rather than paying the entire $1 million, that it becomes milestone payments. There's an upfront payment, but to be a little bit cold about it, if the patient survives till next year, there's another milestone. A year later, there's another milestone. A year later, there's another milestone. And you also zeroed in on one of the big challenges here. In order for this to work effectively, we need data to be shared correctly. Fortunately, there are some examples of value-based healthcare moving into some hospital models like Intermountain Health. This is an example where they actually provide a little bit more care up front so that the overall costs for patients are lower, particularly around mental health, which we care about a lot. Mayo Clinic has an example where they actually slow down surgery so they get pathology results during surgery so that the reoperation rate is lower for lumpectomies and breast cancer. There's another thing that's that people might have heard of around learning healthcare systems. So this is another way to share data back to the system, to the healthcare system around outcomes, which, Seth, I know you talked about this yesterday. Many providers, perhaps all providers, don't really know how well they're doing in terms of their patient outcomes and what's working and what's not working. They'll argue with you because they'll say, I know, I keep track, but if you've got panels of thousands of patients, it's very hard to keep track, very hard to systematically analyze. So a learning healthcare system actually puts data and technology and analytical systems in place to create feedback loops and process changes so that better care is delivered. Getting hard to deliver, but entities such as Google's Verily is trying to invest to set up these kinds of things. I know we're a little bit technically only have 5 more minutes, so let me kind of end with the next concept, which I find fascinating. So as hospitals are changing and thinking about different models, moving towards this more consumer-centric healthcare model. So there's a lot of things that we've been hearing more about retail health, like CVS Minute clinics, and Walmart Health has got a retail health. You know, Walmart Health itself is a retail health type of enterprise that is being rolled out. Hospitals themselves are becoming more consumer-centric, and going back to one of the themes that I started with, of I have an optimistic prediction, maybe overly optimistic, that the power shift is actually moving to the top of the triangle towards patients. And the reason is that because those lower profit margins in hospitals mean that patients are actually getting more choices of where they can go for care, then hospitals need to think of, well, how do I attract either patients or payers or providers? And these are some ideas in the way they're doing that with these kind of buzzwords around the leader. So the leader is the hospital that provides the best in class, highest quality care. People are going to come to me because I'm the best. You know, it's Mayo Clinic, it's Cleveland Clinic, it's Mass General. You know, whether Yale is one of these or fits into a different model, I think we can have a debate over. But they prioritize kind of the best clinical models in clinical care, and they use a lot of referrals and M&A. And so these Mayo, Cleveland Clinic, MGH, which is merged with Brigham and Partners, all of these have actually actively, aggressively been eating up networks of primary care and other providers, so they keep a lot of referrals coming in. So providing the best care works if you've got a lot of volume of coming into your system. Another model is based on customer or patient satisfaction. You know, this is the experience model, the user experience. In this case, it's targeting a somewhat different type of decision, healthcare decision, and in perhaps in more competitive areas where they prioritize understanding what preferences are within their patient population, and probably going after employers, not just, you know, articles about how we did the first, you know, blah 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 transplant. So they have to understand those patient populations better. There's heavy investments in social media, digital systems, and the patient experience really is very different in these types of locations than you get at one of those, you know, at the high end leader experience, where the patient experience can you know, often be quite substandard. Integrators, on the other hand, they go big. They focus on M&A and cost reduction, so they build large multi-regional systems with national reach, and they're basically, you know, their model is you know, go big, and prioritizing lower costs with higher deductible plans, a somewhat healthier population to bolster their revenues. And you know, the third category here is the manager model of population health. Here, these are systems that deliver healthy care as well as disease management. And I'm sorry, they actually deliver disease management as opposed to fee-for-service, you know, reactive care for diseases for sick people. So, you know, they're more apt to use risk-based models and value-based models. They're more apt to you know, work with communities to provide integrated care that go beyond traditional services. You know, Kaiser and Geisinger are good examples in this space. You know, Kaiser in fact is well known for using a lot of different systems, such as IT systems and data, but they're also well known that they're proactive with their patients. So they practice population health, which brings down costs from a different point of view, not by cutting costs, but by trying to keep their patients healthier. So it's 4:23. I do have a couple more slides, but I want to ask I don't know who's the time cop here, whether it's Patricia or Barb.
I've been trying to do it, but I'm so bad at it that Mfundi pings me. So, you know, how many more slides do you have, Greg?
Well, I mean, my last couple of slides really try to talk a little bit more about more patient choice, patient focused, consumer focused models, more app-based stuff. I can go through those, you know, in about a minute. It's, you know, it just runs the risk.
Let's do it. We don't want to leave folks hanging. Yeah.
Okay, all right. At the risk of being a little bit data overloaded. So there are a number of models that now the system is, entrepreneurs in the system are looking at to go back to kind of the original premise. Power is shifting in a system that's very complicated and has many pain points and many hassle factors. So many things are popping up as viable alternatives, you know, such as, you know, personalized health solution, information, data on a request, patient experience benchmark, telemedicine, etc. So, you know, just a couple of examples here of, you know, on-demand, on-site. So examples of scheduling on-demand healthcare, telemedicine, or on-demand transport, which disintermediates not hospitals, but ambulances. Another is marketplace. So, you know, healthcare is a bizarre non-marketplace because of those, the principal agent problem. This is trying to use data to create online markets for things like diagnostic labs or non-emergency medical equipment, or you know, in some case services that creates, you know, an Amazon-like marketplace that creates competition, price competition around you know, products, but also some services. I guess that's it. Yeah, my backup slides get super nudgy about reading financial statements, and you know that this session I'll start at 11:30 at night, and we'll go through detail of how to read financial statements. It'll be absolutely fascinating, and everybody will be asleep. But let me stop with that.
So, questions?
And I'm happy to provide. Here, let me end with a thank you slide. Happy to provide. You know, we'll definitely make these slides available.
I have a question.
Greg, you're a surgeon. Why would you have a stethoscope on your slide?
I've heard people use that. You know, I just use it to, like, as a back scratcher.
Okay. My question is, would you say that patients or consumers changing needs for better, more affordable, high quality and convenient care should be a trend that would inform either a business model or innovations that we bring to the fore? What do you think about that?
Well, I mean, I guess I'm going to sort of, you know, make a simple answer and say both. I mean, yeah, you know, can you use innovation, you know, to create more patient-driven healthcare? You absolutely should. You know, again, going back to those first principles of make sure that you've identified the use case and you figured out the problem to solve. You know, same way with using information, same way with using, you know, kind of, you know, being more, you know, basically patient oriented. So I think absolutely right. I think all of those are components. It's hard to say. You know, if one is theoretically more valuable than another. I mean, do you have an opinion about that?
No, I'm just trying to think of the triangle that you created earlier, thinking about the payers, thinking about the providers and the patient. You know, I mentioned that the patient was the main beneficiary, and from this last slide, it showed that most of our focus of course, you have to be patient-centric, but sometimes you're like, okay, what would the payers, what would bring me the best money?
Right.
You know, pay for those innovations, I seem to think about the payers as well and the people that will prescribe it. And then I'll just like, okay, what should be the topmost points?
Yeah, it's an excellent question. So I think one of the main challenges here is if we're creating a patient solution, remember, be mission driven, but don't forget about your profit margin. That somebody's got to pay for it, and the problem is that patients hate paying for stuff out of pocket. Physicians hate paying for stuff. Payers are more used to paying for stuff, but they're kind of cranky about it. So it really depends. I mean, one of the examples that we threw out there was using STAT, which is an alternative to ambulances. That's really not for the provider or the patient. The only beneficiary, or I think the major beneficiary there, is the payer, because it's much less expensive to take a car than an ambulance. And there's lots of examples of things that payers like, because it addresses hassle points in their sphere. So I think who's paying for it is such a critical question in healthcare, and it's so different than retail applications. It really needs to be thought of very carefully. And a pitfall that I see startups, not just MBA students who want to start a company while they're in school, but pretty mature startups really fall into a major pitfall of not thinking through who's going to actually pay for this. And they kind of go along the idea that, well, but this will make it better, but this will be better information for patients. Well, don't patients want better information? Sure, patients want better information about disease, let's say. Great, that's a great product, but who's going to pay for it? It really becomes a major challenge. And the other pitfall is around technology. I mean, I probably, one of the conversations that I have most frequently is people with a technical background who have a technical invention. AI is a great example. They can do AI to analyze data better, faster. It's just better. We can analyze your x-rays better. Okay. And we can do it faster. Okay. And then they ask me, who's going to use this? I'm like, I don't know. I mean, there are many technology-based startups whose premise is we have a Stanford professor whose AI algorithm is better. And they've raised money from venture, and they're trying to experiment with different models, and they're going around interviewing people, basically saying, who do you think would use this? I'm like, well, I don't know. I mean, that's kind of your job to figure it out. The technology's cool, but the technology in of itself doesn't solve the problem. You figure out the problem that needs to be solved, and then go find the technology. I mean, if hard to do for a technologist, right? If that's what they have.
Greg, I feel like you were snooping on my text with Seth. You just asked me, what are we going to talk about in our reflections? And I said, this whole, the past 2 days, we've been talking about, talk to your customer, we started talking about revenue, but we didn't, until this moment, talk about the fact that most of us here on this call, we have a technology. We don't yet have a product because we haven't answered these questions about, what is the need that it solves. We haven't put it up against some market forces. It's once we've figured out all of these feasibility pieces and some other components that we then actually have a product.
Mm-hmm. The way I summarize it, my mantra, and again, many companies that already have funding that already have, you know, or have hired dozens of people, my mantra is, what is the use case? And so many companies, their use cases are they're just flawed, or they're shaky, and they're a little bit dismissive, like, yeah, like, but the founder sold his company to Google for, $1 billion. Like, okay, great. So what's the use case? No. But this is a better chip. It's a better chip. Like, okay, great. What do you use it for? What is the use case? And for me, the use case kind of defines, who the customer is, what their problem is, how much their willingness to pay is. That's frequently what I kind of push back on, whether it's, an entrepreneur with a startup idea or even established companies. Like, tell me a little bit more about these use cases that you've talked about. And I put on my customer hat, like, is this what is your mobile health platform solving for me? And how does your use case make my professional world better?
It's such an interesting thing to me, because many of us maybe are academics, and our sales pitch, our target customer to this point has really been NIH, right? And grants, we write, what is the problem you're trying to solve? And usually that's much more at the public health level, right? We're trying to solve this public health problem, in this case, all of us in the addiction space, using business language. And so that's what I just keep coming down to. Well, I'm trying to solve this public health problem. Well, in a business sense, that's not enough, right? We have to keep reducing it down to, right, and at what level where somebody's actually going to pay for that. So it's just a very interesting thing for me from an academic perspective.
That's right. I mean, and all those pieces have to come together. They do have to balance, in solving public health issues, and, and addressing addiction is critical, absolutely critical. But I guess maybe that's part of my take home here, is that you can probably go pretty far with that. But you kind of want to get to a level of sustainable profitability. You kind of want to get in that 15% range, because otherwise, you're stuck in negative profits, or 1 or 2%, and it's a great idea that addresses a public health problem, but it just is not sustainable.
And on the discovery note, I mean, the truth is, I'll just pick up on Patricia's reflection comment.
Yeah, so we're transitioning to the reflection phase. Cute.
To the reflection as the sun sets behind us. By this point, and for the next couple of days that we're together, I realize we're not together for a couple of days in a row, but like tomorrow and then 2 weeks later, you actually should be confused, right? The whole point is now, like, it should be clear to you. Some of you may have already done some discovery and have real clarity. If that's the case, I assure you, you're wrong. But separate from that, you should be sort of confused, right? Like, the whole point of this was for you to start to question and realize just how messed up the system is and how complicated it is to find a solution. That's sort of, to me, and I think the questions evidence some of it, what I've noticed today, especially in the questions, because it almost seems like people are feeling a little bit strained of like, well, what? Like, I thought the whole point of this was for you to tell me how to take what I have and make sure, I succeed, when in fact, what we're really saying is there's a high likelihood what you have can't succeed. And so part of it is to figure out why, and to either reshape what you're thinking to make it succeed, right? Like, maybe it needs to be totally different. Like, maybe if I have, like Carla, I don't know the details of your thing, but I suspect you're spending a lot of time not with the patient. And it's like, well, that's pretty complicated, because those people are not actually members of the same health plan. So even if you could get a health plan to pay for spending time with that patient for that problem, well, if you're spending a lot of time with everyone but the patient, well, they don't even cover those people, and they pay for face-to-face, right? So there are just many little nuances to anything any of you are doing. I think on the pharmaceutical side, it's really well-tread territory. I think, there are lots of like diagrams of what to do and to go to the FDA with a diagnostic or a therapeutic. Although then you're going to have, really big issues, right? As we've seen all day today around, well, who the heck is going to pay for that? Is it better than what's out there? How much better? And I mean, put a little bit differently, like Greg said, okay, you've got some AI thing that does something better. I mean, we do a pretty crappy job with the low-hanging fruit today. We don't control blood pressure. We use like 10 times as many back surgeries as we should for things that they like. So many things are not done reasonably well. Why would anyone pay for anything better if they're not even doing today what they know is better, right? So there are so many interesting, tragic realities. Doesn't mean we shouldn't do it, but to me, that's kind of like has been a theme throughout the day. Like that's why discovery is so important, and understanding your like the competition. I would argue identify who that competition is and figure out where they're succeeding and understand why they're succeeding there, and then design something better, because you'll understand like who's already paying them and you can do something better around them. I don't know, but I mean, to me, that's sort of the theme I think that I saw today. Margaret's in an interesting position. She's not here now, but she looks at a lot of innovations that come to Yale New Haven Health System. I've been in meetings with her where we've been discussing software that will save lives. Like literally, I've been in meetings with her, and the head of IT will say, yeah, we've got a pretty full list of things we've got to do for the next 18 months. I'm not sure I have a project manager to save lives. That's not how they say it, but that's basically what she says. But tell me that I'll increase my billing rates for like the next quarter and make my nonprofit health system go from making 100 million a year to 110 million a year, not in profit, in excess revenue, because of course it's a nonprofit. They have project managers for that all day and all night. And
so yeah, I think you said a lot. That's really, really cool, thought-provoking. I'm watching the faces and folks smiling. I did want to open it up so they could react.
Any of you tragically depressed and disappointed?
I think what you were talking about is I'm not a huge fan of like using large standout companies as examples, but one looking at, for example, Tesla, and say, for example, if they wanted to, create a product that was beneficial towards climate change. Well, it's like that wasn't ever, maybe that's an idea and maybe that's what they wanted to do, but really they created something that appealed to like people's nature of like wanting a really nice car. And so it's not, they didn't sell it as, being, oh, here's something that helps climate change, but they, it's people want to drive one because they're super nice and they do almost everything better than other cars. So in a way that will then, contribute to, decreasing emissions, et cetera, and accelerate the industry towards that. So that's a really like interesting case study around an idea where you just have a lot of competing incentives, and the nature of large institutions may not be aligned with your goals, but how can you then leverage those incentives to then advance your goals?
Well, what if, I'm going to ask you a question about that, Eric. What if in fact the goal was to make a lot of money and it was just to leverage a group's interest in thinking, right, that they were getting something that was better, and what if in fact they were leveraging the incentive that a particular group thought they had, because the reality is, we're 18 years or something into Tesla's journey. So I would say, what if in fact they were trying to solve a different problem that you're completely unaware of, but they leveraged your interest in those two issues, thinking you were getting a better car, or thinking you were in fact impacting climate change, because I think most people who bought it in fact did think about that, right? That the battery was going to not emit greenhouse gases. What if they were trying to take advantage of something they knew that you, the customer, had for a totally different aim?
Well, so I feel like that's that hits on the importance of messaging, right? And so that's really one of the most crucial elements of any sort of product development scheme, is just the messaging to each stakeholder and each, you know, consumer, et cetera. But again, you know, if they were trying to make a profit, they didn't do a very good job for, you know, a decade or more. But, you know, again, I think, you know, just listening to people who were innovators there, one of their ideas was that this was a problem that needed addressing, and the messaging of this is a green solution wasn't going to sell it. And so the messaging of this is a luxury, nice vehicle that a lot of people want to buy because it looks prestigious and that it's just nice and that it's very low maintenance and et cetera, et cetera. That's what ended up on their marketing side selling, you know, as many units as they did.
Yeah,
So.
Right. I think it's a great point.
I was struck by the presentation this morning on, you know, what would it take for us to build a system that tracks opioid use in a hospital system? You would think, you would sort of like hope that the motivation to build something like that would be more about like tracking use and it's too much, or like, but really what seems like motivated systems to build it was people are stealing them. And it wasn't like, oh gosh, I can understand that my hospital is prescribing opioids too much in this clinic, and so I can reduce it. But it seems like they backed into creating such a system.
Yeah, and by the way, that's 19 years after OxyContin went on the market. It's not like these problems were new, but all of a sudden there was liability, right? People were found dead in closets who worked there, right? Who overdosed, and there were like penalties, which is a really, you know, that's also right, a really fascinating point. You know, what, and any other takeaways from that, Zach? I mean, how does that reshape the way you think about what you're doing?
I haven't quite thought that through, other than I've had, you know, we're trying to build a product that improves the quality of psychotherapy, and we've had payers tell us that they don't care about that.
Yeah, I could have told you that. I could have saved you a lot of time.
Yeah, well, I mean, I don't know what we thought we were going to hear, but it was definitely, you know, so if you still believe at some level.
I think that's awesome. I can't wait to talk to you more about it. Like,
well, do you have $100 million?
No, I know. Oh, but it is an interesting thing of like, how do you get people to care? Like that's, and I'm coming into so like Pollyanna, I think, and like, really, no, I want to fix this public health problem. I'm not thinking about profit, although money would be nice too. But Dr. Jim Withers, are folks familiar with him and his street medicine that he founded? One of my all-time heroes, Pittsburgh, I think 20 plus years ago, he would walk in the cold winter, you know, streets of Pittsburgh, walk by homeless people on his way to do his residency, I think emergency medicine, internal medicine, something. And he would notice that like the same guy that had like a little bit of start of frostbite would be then the same guy, you know, on his toes would be the same guy coming in. They'd have to amputate like half the leg. And he's like, gosh, I could have fixed that and saved lots and lots of pain and suffering. And so he started borrowing supplies from the hospital and going and treating these folks on the street. And as part of doing that, and it was just because he wanted to help, right? And as part of doing that, he started coming up with a tracking system. Like a lot of times, of course, comorbid mental health problems, they wouldn't give you their whole name. So this is Bob, and Bob's on the corner of X and Y, and so on and so on. And then there was a nurse who then kind of caught on to what he was doing and became his partner in crime. And they got busted. And, you know, it could have been really bad, but instead, what he was able to do was show, look at the money we're saving. You know, this is what the money we're saving the hospital. Like, this is what amputation costs. This is what it costs to treat a little bit of frostbite if I can go there, because they're not going to come to us. And so now there's this residency that you can get that's all over the country called street medicine. I think it's Operation Safety something. And it's incredible. And I just keep thinking about, like, I truly believe he wasn't thinking about profit or, you know, a product, but he wanted to solve this incredible medical problem facing them. So that's where I'm coming from this. And so Zach, don't give up, because that's so important.
Yeah. What I can say, just to chip in, Zach, is that I'll take a big takeaway that I got from said just now is that with a very fantastic technology, what you have to do is to identify competitors, what they're doing well, who is paying them, why they're being paid, and then you do yours better and get those similar kind of payers. So I think that's something I took away from there, that rather than to be successful, I have to like, okay, I have this wonderful innovation, this new product, who else is doing it? What are they doing to succeed? Who is paying them? Then go after those investors and present mine as being better and get them to fund me. I mean, that's my key takeaway from here just now. Yeah.
Well, Zach and Carla, I think.
One comment. Go ahead, Janie.
Oh, thanks, Rick. You know, in listening today to Tom Knight, who I thought was just phenomenal, you know, he had his reason for wanting to be in the space. And then as he talked to people and he really listened, right? And he listened and he heard where they were having issues, which were totally different than his motivation, but he still had the technology to solve it. And so I think it's that listening, right? So it's not that you're trying to convince them, Carla. I don't think that that's going to work as well, right? So in your example, you know, this resident was really touched and moved by what he observed, but what made him scale and grow was the financial piece, which was somebody else's value system. But it doesn't mean that, you know, yours isn't important. It's just being able to detach enough that you can really listen, because I think that's hard, right? We come with our biases and our interests and our values, and we maybe are making value judgments on people where if we're just listening, really openly listening, we might find these synergies that become win-win scenarios for both us and them, even if we're coming from different perspectives. Rick.
Janie, I agree with that. And let me just build on that. It dovetails with the point I was going to make. What I've been hearing, which is wonderful, and it's a great conversation. What I've been hearing are a couple of examples of things that are what they've been purported to be, but I think there's something else. I think the Tesla example, I think the street medicine example, and a couple others might easily fall under the heading of extraordinarily sensitive and innovative customer research. People are really starting to understand the entire spectrum of the motivations and need for solutions among the people that are ultimately going to be your customers and your payers. And really getting a sense of what that range might be and finding the soft spot. The Tesla one is great. I mean, at the end of the day, no matter what they were trying to do, they figured out that no one was going to buy an electric car unless it went zoom, zoom, period. And everything else was built on that. And likewise, I suspect that the street medicine thing, although it was a eureka moment, somewhere in there, that doctor said, you know, I know how I can get these guys to do what they should be doing as human beings. They're not human enough to do it, but I can give them the incentive. And these are perspectives that, with experience and over time, people who are entrepreneurs who sometimes change the world either discover them because of their diligence or their brilliance, or sometimes they just stumble upon them. But either way, it happens. And
You
then
know,
you get change.
I am so glad you said that. My day started with a confidential talk that I was a part of, you know, but I can share this because it's not confidential, which is stumbled on. So this, I think, is a really important point, which is luck. There's a huge, don't underestimate the power and importance of luck. And, you know, you try hard, you have a great idea, you're solving a problem, you do your discovery, but at the end of the day, there's a huge positive selection bias in all of these stories because you don't read about all the massive failures. You only read about a few of them. You read about all the huge successes. And they are outliers, and there is always luck, always.
Yep.
And so
And
whether—
Seth, who was it who said, the harder I work, the luckier I get?
Other than you? I don't know.
Somebody did, but they do go hand in hand. And
Oprah Winfrey says that.
And I think, and the person who said it this morning, I don't know if you know this guy, you know, who founded the Carlyle Group, who interviews people. His name is Rubenstein. He does like these really in-depth interviews with business leaders. It was just part of this other thing today. And that was the thing he said. There's always luck, you know, and here's a guy who's, you know, like achieved extraordinary fortune in many fronts. And he's, you know, a wonderful interviewer and a very insightful guy. And so, like, I mean, when you think about electronic medical records, right? We all now, we know Cerner, right? These companies were nothing until the Affordable Care Act flooded money into the system to pay for EMR implementation. They were all struggling to make their businesses go. Had that never happened, we'd barely have penetration of EMRs. I mean, that was a government action that was based on trying to achieve, you know, broad coverage and data flow. That was pure luck. If it took a few more years, some of those companies may have been out of business. So it's easy to look back at people like Faulkner and, you know, Allscripts Management, et cetera, and say they were brilliant, but there were people trying EMRs before them, and there were people trying EMRs at the same time that were coming a little bit too late. They just happened to, they were smart, they worked hard, but there was luck involved. Yeah.
Yeah, so this has been a really great conversation, and we have about 5 minutes left. And Flindy came up with a nice closer for us that I'm excited to run through, where he suggested that we just all go around the Zoom room and say one word about how we're feeling about today. And so I will read off of my screen. And so Annette, you're at the top. It's almost like you knew. One word.
Well, I feel great to be with all of you. It's more than one word, but.
That's fine. Julie.
Swirling.
Great. Eric.
I'm really curious.
Curious, yeah. Roger.
It's learning a lot of things.
Learning a lot of things. Carla.
Challenged.
Yep, challenge. Janie.
Grateful to be in your presence.
Thing.
I guess I would say inspired.
Yeah. Seth.
Oh, do I have?
One word.
Energized.
Good. Ayo.
Enlightened.
Wow. Eric.
Curious.
Curious. Great. Erica.
I'd say it's not really one word, but maybe gambling.
Gambling. Great. Zach.
Validated.
Wow, that's a good one. Rick.
I'm invigorated.
Me too. Anand.
Well, thanks to the talks, focused.
Great. Jamila.
Optimistic.
Great. Fantastic. Andy.
Encouraged.
Encouraged. Good. Janice.
Thoughtful.
Thanks. That's a good one. Johannes.
Interested.
Very nice. Trina.
Motivated.
Woohoo. Laszlo.
It's overwhelmed but thankful.
Great. Greg? Can we get him?
I
I'll
think
come back.
you might have had to jump off or
Yeah. Barb?
I'm gonna say hopeful.
Yeah. Great. I'm not sure if Chris is on. I'll go to him. Flindy.
Content.
Content.
Not tired?
Right. And I am delighted. So thank you all for your passion around this area, your attention, and everything that you're bringing to this week. I still want to call it a week because it's usually a week. So enjoy the rest of your evening. Oh, and Chris is online. Chris, I won't let you get away. Yep. What are you feeling?
I have to say, very interested by all your conversations.
Thank you. Thank you for helping us make sure this all goes smoothly. We've all been on edge about this digital situation. So thanks, everyone.